Hey guys, tonight we dive into the brutal, horrifying, and surprisingly hopeless world of medieval bone treatment. Those learned physicians who claimed to heal broken bones with methods that would make modern doctors weep with horror. While medical dramas make us think healing has always been noble and scientific, the reality is that medieval bone treatment was a nightmare of ignorance, superstition, and techniques that usually made injuries far worse than leaving them alone. So before you settle in, take a moment to like the video and subscribe, but only if you genuinely enjoy what I do here, and let me know in the comments where you're watching from and what time it is for you. It's always fascinating to see our global audience. Now grab something to numb the pain, maybe avoid looking at your own bones, and let's explore the terrifying world of medieval orthopedics. Let's destroy the first comforting myth right away. Medieval doctors didn't have sophisticated techniques for treating broken bones that were lost to time. They had no techniques at all. When someone broke a bone in medieval times, the best thing that could happen was that no doctor would get involved. The worst thing was that a learned physician would arrive with his bag of tools and his complete ignorance of human anatomy, ready to turn a simple fracture into a life-threatening catastrophe. Medieval medicine operated on the assumption that the human body was a mystery that could only be understood through ancient texts, religious doctrine, and pure guesswork. Doctors had never seen the inside of a human body, had no understanding of how bones actually worked, and based their treatments on theories that were not just wrong but actively dangerous. When they encountered a broken bone, they didn't see a mechanical problem that needed careful alignment and immobilization. They saw a spiritual crisis, a humoral imbalance, or an opportunity to demonstrate their learning through elaborate and completely useless procedures. The concept of setting a bone properly was alien to medieval physicians. They understood that bones were hard and that breaking them was bad, but beyond that, their knowledge was a toxic mixture of ancient Roman medical texts, religious superstition, and folk remedies that had been passed down through generations of people who had never successfully treated a fracture. The few medical texts available were copies of translations of Greek and Roman works that had been corrupted through centuries of transcription errors, misunderstandings, and deliberate modifications by scribes who thought they knew better than the original authors. Medieval doctors didn't just lack knowledge, they were actively misinformed by authoritative sources that taught them to do exactly the wrong things in exactly the wrong ways. The result was a medical system that was not just ineffective but genuinely harmful, turning minor injuries into major disabilities and simple fractures into death sentences. The training of medieval doctors was a masterclass in how to be confidently wrong about everything. Medical education consisted of memorizing ancient texts without any practical experience, learning to argue about theoretical points that had no relationship to reality, and developing an unshakable confidence in methods that had never actually worked. Students would spend years studying the works of Galen, a Roman physician who had never dissected a human body and based his anatomical knowledge on animal dissections and pure speculation. They would learn that the body was governed by four humors: blood, phlegm, yellow bile, and black bile that needed to be kept in perfect balance for health. They would memorize elaborate theories about how different foods, seasons, and planetary alignments affected human health. But they would never see a real broken bone, never practice setting a fracture, and never learn the basic mechanical principles that govern bone healing. When these thoroughly educated physicians encountered their first real patient with a broken bone, they were completely unprepared for the reality of dealing with actual human anatomy. They would approach the injury with complete confidence in their theoretical knowledge and proceed to make decisions that were guaranteed to cause maximum harm while following the best medical practices of their time. The problem wasn't that medieval doctors were stupid or evil, it was that they had been systematically trained to believe things that were completely wrong. They thought they were applying the best available knowledge when they were actually following instructions for disaster. Their confidence in their methods made them dangerous, and their authority in society meant that patients had no choice but to submit to treatments that were worse than no treatment at all. The gap between what medieval doctors thought they knew and what was actually true was so enormous that it's almost impossible for modern people to comprehend. Imagine trying to fix a car engine using instructions for baking bread, while being absolutely convinced that you're following the correct manual. That's essentially what medieval bone treatment involved: learned professionals applying completely irrelevant knowledge with absolute confidence and terrible results. So no, medieval doctors didn't have lost wisdom about bone treatment. They had confident ignorance wrapped in academic authority, and the results were exactly as horrific as you'd expect when people who understood nothing about bones decided they were experts in bone repair. The medieval understanding of human anatomy was so fundamentally wrong that it's almost impressive in its complete disconnection from reality. Doctors believed that bones were solid, homogeneous structures that functioned more like wood or stone than living tissue. They had no concept of bone marrow, blood supply, or the complex cellular processes that allow bones to heal naturally. To medieval physicians, a broken bone was like a broken stick that needed to be tied back together, except they didn't even understand how to tie sticks together properly. The four humors theory dominated all medical thinking, including bone treatment. According to this system, broken bones were caused by an excess of cold, dry humors that made the bones brittle, or an excess of hot, wet humors that made them soft and prone to breaking. The solution wasn't to set the bone properly, but to restore humoral balance through bloodletting, purging, and the application of various substances that would theoretically counteract the humoral imbalance. Doctors would diagnose the specific humoral cause of a fracture by examining the patient's urine, checking their pulse, and consulting astrological charts to determine which planetary influences had contributed to the injury. They would then prescribe treatments designed to address the underlying humoral problem rather than the actual broken bone. If they determined that the fracture was caused by excess cold humor, they would apply hot poultices and herbs. If they blamed excess moisture, they would try to dry out the patient through various means. Medieval physicians also believed that the body was a microcosm of the universe, with each part corresponding to celestial bodies and divine influences. Bones were associated with Saturn, the planet of limitations and restrictions, which meant that bone injuries were often treated as spiritual problems requiring religious intervention as much as medical treatment. Doctors would time their treatments according to astrological calculations, wait for favorable planetary alignments, and incorporate prayers and religious rituals into their medical procedures. The concept of infection was completely unknown to medieval medicine. Doctors had no understanding of bacteria, sterile technique, or the importance of cleanliness in medical procedures. They would examine broken bones with dirty hands, use contaminated instruments, and apply treatments that introduced foreign matter directly into wounds. What they interpreted as natural healing processes were often actually signs of infection, gangrene, or other complications that they attributed to spiritual or humoral causes. Medieval understanding of pain was equally misguided. Doctors believed that pain was caused by the movement of corrupted humors through the body, not by actual tissue damage or nerve responses. They would often increase pain through their treatments, interpreting the patient's suffering as evidence that the corrupted humors were being expelled from the body. The idea that pain might indicate that their treatment was making things worse never occurred to them. The role of blood in bone healing was completely misunderstood. Medieval doctors knew that bleeding often accompanied bone fractures, but they interpreted this as evidence that excess blood needed to be removed from the body rather than as a sign of tissue damage that needed to heal. They would often increase bleeding through bloodletting, believing that this would speed recovery by removing the corrupted humors that had caused the fracture. The medieval understanding of human movement and biomechanics was similarly flawed. Doctors had no concept of how muscles, tendons, and ligaments work together to support bone function. They saw these tissues as separate, unrelated structures rather than as integrated systems that needed to work together for proper healing. This led to treatments that ignored the importance of proper alignment, muscle function, and joint mobility in bone recovery. Even the basic concept of immobilization was misunderstood by medieval physicians. While they sometimes recognized that broken bones shouldn't be moved too much, they had no understanding of why this was important or how to achieve proper immobilization. Their attempts at splinting were often more harmful than helpful, causing additional damage through improper positioning or excessive pressure. The medieval medical system also failed to distinguish between different types of bone injuries. A simple fracture, a compound fracture, a dislocation, and a severe crushing injury would all be treated with similar methods because doctors lacked the knowledge to understand the different healing requirements of different types of bone damage. This one-size-fits-all approach to bone treatment guaranteed poor outcomes even in cases where proper treatment might have led to full recovery. So when medieval doctors encountered a broken bone, they weren't working with incomplete knowledge that could be supplemented with common sense. They were working with a completely fictional understanding of human anatomy that led them to do exactly the wrong things with absolute confidence. Their treatments weren't just ineffective, they were actively harmful, turning manageable injuries into permanent disabilities or fatal complications. The actual techniques that medieval doctors used to treat broken bones were a horrifying combination of religious ritual, folk superstition, and procedures that seemed designed to cause maximum suffering while providing no benefit. These weren't primitive attempts at real medicine, they were elaborate ceremonies that had no relationship to the actual medical needs of patients with bone injuries. The first step in medieval bone treatment was almost always bloodletting, based on the theory that broken bones were caused by an excess of blood that created pressure and heat in the injured area. Doctors would make incisions near the fracture site, apply leeches to draw out corrupted blood, or open veins in other parts of the body to reduce the overall blood volume. This weakened patients who needed all their strength for healing and often introduced infections that were far more dangerous than the original injury. The amount of blood removed was often determined by astrological calculations rather than the patient's condition, with doctors consulting star charts to determine the optimal timing and quantity for bloodletting procedures. Purging was another standard treatment, involving the use of powerful laxatives and emetics to expel corrupted humors through the digestive system. Patients with broken bones would be forced to consume substances that caused violent vomiting and diarrhea, further weakening their bodies and making healing more difficult. Doctors believed that these substances were driving out the internal poisons that had caused the bone to break, but in reality they were simply adding dehydration and malnutrition to the patient's problems. The application of poultices and ointments was a central part of medieval bone treatment, but the substances used were chosen based on theoretical principles rather than any understanding of what might actually help bone healing. Hot poultices made from animal dung, rotting meat, or fermented plant matter were applied directly to open wounds, introducing bacteria and causing infections that often led to gangrene and amputation. Cold applications included mixtures of urine, vinegar, and crushed insects that were believed to draw out heat and moisture from the injured area. Medieval doctors also used a variety of herbal preparations that were supposed to have bone-healing properties, but these were selected based on superficial resemblances to bones rather than any actual therapeutic effect. White substances like powdered chalk or crushed eggshells were applied to fractures because they looked like bones. Plants with hard, woody stems were used because they shared certain visual characteristics with bone tissue. The doctrine of signatures, which held that God had marked healing substances with visual signs of their therapeutic purposes, led to treatments that were based entirely on appearance rather than effectiveness. Splinting techniques in medieval medicine were crude and often counterproductive. Instead of using rigid materials to immobilize the fracture site, doctors would often use soft bandages soaked in various solutions that provided no structural support while keeping the wound moist and prone to infection. When they did use rigid splints, these were often positioned incorrectly or applied with so much pressure that they cut off blood circulation and caused additional tissue damage. The binding materials used for splints were frequently contaminated with bacteria, introducing new sources of infection to the injury site. Some medieval doctors attempted to realign broken bones through manipulation, but they had no understanding of proper anatomical positioning or the forces required for effective bone setting. They would often cause additional fractures or damage to surrounding tissues through aggressive handling of the injured area. The concept of gentle, controlled movement was unknown to medieval medicine, which favored dramatic interventions that looked impressive but caused more harm than benefit. Heat treatment was another common medieval bone remedy, involving the application of red-hot irons, heated oils, or burning substances directly to the skin over fracture sites. Doctors believed that intense heat would drive out the cold humors that had made the bones brittle and prone to breaking. These treatments caused severe burns that often became infected and created permanent scarring and tissue damage that made recovery more difficult. The use of religious relics and blessed objects was considered an essential part of medieval bone treatment. Doctors would place fragments of saints' bones, holy water, or consecrated oils on the injury site, believing that divine intervention was necessary for proper healing. While these treatments were harmless in themselves, they often delayed or replaced more practical interventions that might have actually helped the patient. Bloodletting was sometimes combined with the application of sacred substances to create treatments that were both medically harmful and religiously meaningful. Some medieval physicians practiced a form of bone setting that involved attempting to force broken bone fragments back into position through external pressure and manipulation. However, they had no understanding of bone anatomy or the healing process, so these attempts often caused additional damage to muscles, nerves, and blood vessels around the fracture site. The idea of using X-rays or other imaging techniques to guide bone setting was obviously impossible, so doctors were essentially working blind while applying potentially dangerous forces to injured tissues. Traction devices were sometimes used in medieval bone treatment, but these were crude contraptions that often applied too much force or pulled in the wrong directions. Patients would be subjected to prolonged stretching that could cause additional injury while providing no therapeutic benefit. The weights and pulleys used in these devices were often improvised from available materials and had no standardized measurements or safety features. Perhaps most disturbing were the surgical interventions that some medieval doctors attempted on broken bones. Using crude instruments and no understanding of anatomy, sterile technique, or pain management, they would sometimes try to remove bone fragments or explore fracture sites through open surgery. These procedures had mortality rates approaching 100% due to infection, blood loss, and traumatic shock, but they were considered advanced medical techniques by physicians who had no concept of the risks they were creating. So medieval bone treatment wasn't just ineffective, it was systematically harmful, taking patients who might have recovered naturally and subjecting them to procedures that guaranteed poor outcomes. The elaborate nature of these treatments gave the illusion of sophisticated medical care while actually ensuring that broken bones would heal poorly if they healed at all. The pain management techniques used in medieval bone treatment were almost as horrifying as the treatments themselves, based on the belief that suffering was either spiritually beneficial or medically necessary for proper healing. Medieval doctors had no understanding of anesthesia, pain pathways, or the physiological stress that pain placed on healing bodies. They often viewed pain as a positive sign that their treatments were working, rather than as a symptom that needed to be addressed. The most common approach to pain management was simply to ignore it or to interpret it as evidence that corrupted humors were being expelled from the body. Patients were expected to endure procedures that would be considered torture by modern standards, often while being held down by assistants who prevented them from moving during painful manipulations of broken bones. The medieval belief system held that suffering was morally purifying and that enduring pain without complaint was a sign of spiritual strength. Opium was known to medieval medicine and was sometimes used for pain relief, but it was expensive, difficult to obtain, and often adulterated with other substances that reduced its effectiveness or made it dangerous. Even when pure opium was available, doctors had no understanding of proper dosing, leading to overdoses that could cause respiratory depression and death. The use of opium was also considered morally questionable by religious authorities who believed that avoiding suffering was contrary to Christian virtue. Alcohol was more commonly used as a crude anesthetic, but medieval understanding of its effects was limited to the observation that drunk people seemed to feel less pain. Patients would be given large quantities of wine or ale before bone-setting procedures, but this often led to vomiting, dehydration, and poor decision-making that made medical procedures more dangerous. Drunk patients were also more likely to move unexpectedly during treatment, causing additional injury to themselves and making it harder for doctors to perform their already inadequate procedures. Herbal preparations were sometimes used for pain relief, but these were selected based on superstition and folk tradition rather than any understanding of their pharmacological properties. Mixtures containing plants like mandrake, henbane, or hemlock were used as pain relievers, but the active compounds in these plants were poorly understood and often toxic. Patients might experience hallucinations, seizures, or organ failure from herbal pain remedies that were supposed to help them cope with bone injuries. Some medieval doctors used distraction techniques that were supposed to redirect the patient's attention away from pain, but these often involved additional forms of physical or psychological stress that made the overall experience worse. Patients might be subjected to loud noises, bright lights, or strong smells that were thought to overwhelm their senses and reduce their awareness of pain from bone procedures. The theory was that the mind could only focus on one sensation at a time, but in practice these distraction techniques simply added new sources of discomfort to the existing pain. Physical restraints were commonly used during bone treatment procedures, not primarily for pain management but to prevent patients from interfering with medical procedures. Patients would be tied to tables or held down by multiple assistants while doctors manipulated broken bones, applied hot irons, or performed other painful interventions. The restraints themselves often caused additional injury through rope burns, circulation problems, or muscle strain from struggling against the bonds. Cold applications were sometimes used in an attempt to numb pain, but medieval doctors had no understanding of how cold affected nerve function or tissue metabolism. They might apply ice, snow, or cold metal objects to injury sites, but without proper technique or timing, these treatments often caused frostbite or other cold injuries that created additional medical problems without providing effective pain relief. The psychological aspects of pain were completely ignored by medieval medicine, which had no concept of the relationship between fear, anxiety, and pain perception. Patients who were terrified of medical procedures experienced more pain and healed more slowly, but doctors interpreted emotional distress as moral weakness rather than as a medical issue that needed to be addressed. The intimidating appearance of medical instruments and the threatening demeanor of physicians often increased patient suffering without any therapeutic benefit. Some medieval doctors believed that pain was caused by demons or evil spirits that had entered the body through the injury site, leading to exorcism rituals that were supposed to drive out supernatural sources of suffering. These religious interventions might provide some psychological comfort to patients who shared the same belief system, but they did nothing to address the physical causes of pain and often delayed more practical interventions. The combination of physical agony and spiritual terror that accompanied these procedures created trauma that could last long after the original injury had healed. The concept of patient comfort was essentially unknown in medieval medicine, which focused entirely on theoretical treatment goals rather than on the patient's subjective experience. Doctors were trained to ignore patient complaints and to interpret resistance to treatment as ignorance or moral failing rather than as legitimate feedback about the effectiveness or appropriateness of medical interventions. This adversarial relationship between doctor and patient made medical care a battle rather than a collaborative effort toward healing. The timing of pain relief interventions was often poor, with medications or other comfort measures being provided too late to be effective or in combinations that created dangerous interactions. Medieval doctors had no concept of preemptive pain management or of the importance of maintaining consistent levels of pain relief throughout the treatment and recovery process. Patients would experience waves of intense suffering followed by periods of inadequate relief that made the overall experience more traumatic. So pain management in medieval bone treatment wasn't just primitive, it was often actively harmful, adding psychological trauma and physical stress to injuries that were already being treated with ineffective and dangerous methods. The medieval approach to pain reflected a complete misunderstanding of human physiology and psychology that made medical care an ordeal that many patients didn't survive. The tools and equipment used in medieval bone treatment were crude, contaminated, and often more dangerous than the injuries they were supposed to treat. These instruments reflected the medieval understanding of medicine as a combination of craftsmanship, religious ritual, and theoretical application rather than as a scientific discipline based on understanding human anatomy and physiology. Medieval medical tools were typically made by blacksmiths or other craftsmen who had no medical training and no understanding of the specific requirements for medical instruments. The result was equipment that looked impressive but was poorly designed for actual medical use, often causing additional injury while failing to accomplish therapeutic goals. Bone saws used in medieval medicine were essentially carpentry tools that had been adapted for medical use without any consideration of the differences between cutting wood and cutting living tissue. These saws were crude, difficult to control, and impossible to sterilize properly. They produced ragged cuts that damaged surrounding tissues and created wounds that were prone to infection and poor healing. The teeth of medieval bone saws were often irregularly spaced and poorly sharpened, making them more likely to bind, slip, or cause uncontrolled damage during use. Forceps and grasping tools were similarly crude, with rough surfaces and poor articulation that made delicate manipulation of bone fragments impossible. These instruments were designed for grasping large objects with considerable force rather than for the precise handling required in medical procedures. They often crushed or displaced bone fragments that a skilled surgeon might have been able to reposition properly, turning simple fractures into complex injuries that were unlikely to heal correctly. Hammers and mallets used in medieval bone setting were borrowed from construction and metalworking trades, with no modification for medical use. These tools were designed for striking hard, inanimate objects rather than for the controlled force application needed in medical procedures. Medieval doctors would use these crude implements to attempt bone realignment, often causing additional fractures or soft tissue damage that made recovery more difficult or impossible. Heating implements used for cauterization were among the most dangerous tools in the medieval medical arsenal. Red-hot irons, heated knives, and burning substances were applied directly to tissue with no understanding of proper temperature control or tissue response to heat. These tools caused severe burns that often became infected and created permanent scarring and functional impairment that was worse than the original injury. The lack of temperature regulation meant that tissues were often completely destroyed rather than therapeutically modified. Drilling and boring tools were sometimes used to create holes in bones for drainage or to release pressure, but these were crude hand-operated devices that were difficult to control and impossible to position accurately. Medieval doctors had no understanding of bone anatomy or the location of important structures like nerves and blood vessels, so these procedures often caused additional damage while providing no therapeutic benefit. The drill bits were often contaminated and irregular, creating ragged holes that were prone to infection. Binding materials used for splints and bandages were often contaminated with bacteria, parasites, or other harmful substances. Cloth that had been used for other purposes, animal skins that hadn't been properly prepared, and plant fibers that contained irritating compounds were commonly used to secure splints or cover wounds. These materials often caused skin reactions, infections, or allergic responses that complicated the healing process and created additional medical problems. Measuring devices for determining proper bone alignment or limb length were essentially non-existent in medieval medicine. Doctors had no standardized methods for assessing whether bones had been properly set or whether healing was progressing normally. This meant that treatments were based on guesswork and subjective impressions rather than on objective measurements that could guide therapeutic decisions. Cutting instruments like knives and scalpels were often shared between multiple procedures without any cleaning or sterilization between uses. These tools became contaminated with blood, pus, and tissue from previous patients, spreading infections and diseases between different cases. The metal used in medieval cutting instruments was often of poor quality, leading to blades that dulled quickly, corroded easily, and were difficult to maintain in sanitary condition. Leverage devices used for bone manipulation were crude contraptions made from available materials like ropes, pulleys, and weights that had no standardized specifications or safety features. These devices could apply excessive force in uncontrolled directions, causing additional fractures or soft tissue damage while failing to achieve proper bone alignment. The operators of these devices had no training in their proper use and no understanding of the forces they were applying to injured tissues. Storage and transportation of medical instruments was haphazard, with tools being kept in contaminated containers or carried in bags that exposed them to dirt, moisture, and other sources of contamination. Medieval doctors had no concept of sterile technique or instrument care, so their tools were often more likely to cause infection than to provide therapeutic benefit. The lack of proper maintenance also meant that instruments deteriorated quickly and performed poorly when they were needed most. Improvised tools made from available materials were commonly used when proper medical instruments weren't available, leading to treatments that were even more dangerous and ineffective than those performed with standard equipment. Doctors might use kitchen knives, farming implements, or household objects for medical procedures, with predictably terrible results. These improvised instruments had no safety features and were designed for completely different purposes than medical treatment. So the tools used in medieval bone treatment weren't just primitive versions of modern medical instruments, they were dangerous weapons that were more likely to cause harm than to provide benefit. The crude nature of these tools reflected the medieval understanding of medicine as a mechanical craft rather than as a scientific discipline, and the results were exactly as horrific as you'd expect when people used carpentry tools to perform surgery. The long-term outcomes of medieval bone treatment were universally terrible, with patients facing lifelong disabilities, chronic pain, and functional impairments that made their lives miserable even when they survived the initial treatment. The medieval medical system didn't track patient outcomes or learn from failures, so the same ineffective and harmful treatments were repeated generation after generation without any improvement or recognition of their inadequacy. Bone malunion was the best possible outcome for patients who received medieval bone treatment, meaning that their fractures healed in incorrect positions that caused permanent deformity and functional limitation. Medieval doctors had no understanding of proper bone alignment or the importance of maintaining normal anatomy during healing, so even their most successful treatments resulted in crooked limbs, shortened bones, and joints that didn't function properly. Patients with malunited fractures faced lifelong problems with mobility, strength, and pain that made normal activities difficult or impossible. Chronic infection was an extremely common complication of medieval bone treatment, often persisting for years or decades after the original injury. The introduction of contaminated materials during treatment, the use of dirty instruments, and the lack of understanding about wound care created conditions that were ideal for bacterial growth. These infections often spread to surrounding tissues, caused bone destruction, and led to systemic illness that could be fatal even years after the initial treatment. Non-union, where broken bones failed to heal at all, was another frequent outcome of medieval bone treatment. The trauma caused by medical interventions, the disruption of blood supply through improper handling, and the introduction of foreign materials into fracture sites prevented normal bone healing and left patients with permanently unstable and painful injuries. These patients often faced lifetime disability and chronic pain that made productive work impossible. Amputation was often the ultimate result of medieval bone treatment, either as a planned intervention when other treatments failed or as an emergency measure when infections or gangrene threatened the patient's life. Medieval amputation techniques were crude and dangerous, with high mortality rates and poor outcomes for survivors. Patients who underwent amputation faced not only the loss of their limb but also the social and economic consequences of disability in a society that provided no support for disabled individuals. Nerve damage from medieval bone treatment procedures often caused permanent loss of sensation or motor function in the affected limb. Medieval doctors had no understanding of nerve anatomy or function, so their treatments often damaged delicate nerve structures that could never regenerate. Patients might lose the ability to feel touch or pain in their injured limb, making them vulnerable to additional injuries that they couldn't detect. Blood vessel damage during bone treatment procedures could cause permanent circulation problems that led to tissue death, chronic swelling, and increased susceptibility to infection. Medieval doctors often cut or crushed major blood vessels during their attempts at bone setting, creating circulation problems that persisted long after the original injury had healed. These vascular complications could cause ongoing pain, weakness, and tissue breakdown that made the affected limb essentially useless. Joint stiffness and loss of range of motion were inevitable consequences of medieval bone treatment, as doctors had no understanding of the importance of early mobilization or proper rehabilitation. Patients were often immobilized for extended periods in incorrect positions, leading to permanent contractures and arthritis that severely limited their ability to use the affected limb. Even simple activities like walking or grasping objects became difficult or impossible for patients with joint complications from bone treatment. Chronic pain was a universal outcome for patients who received medieval bone treatment, caused by nerve damage, improper bone healing, chronic infection, and joint dysfunction. Medieval medicine had no effective treatments for chronic pain, so patients faced lifelong suffering that affected every aspect of their daily lives. The constant pain made sleep difficult, reduced appetite, and caused depression and anxiety that were themselves untreatable medical conditions. Economic consequences of poor bone treatment outcomes were devastating for patients and their families, as disability often meant loss of income and increased medical expenses in a society with no social safety net. Patients who couldn't work because of bone treatment complications faced poverty and social isolation that affected their entire families. The cost of ongoing medical care for complications often exceeded what families could afford, leading to additional suffering and neglect. Social stigma associated with disability made life even more difficult for patients with poor bone treatment outcomes, as medieval society viewed physical deformity as a sign of moral failing or divine punishment. These patients often faced discrimination, rejection, and social isolation that compounded their physical suffering. Marriage prospects, employment opportunities, and social relationships were all negatively affected by the visible consequences of medieval bone treatment. Psychological trauma from the experience of medieval medical treatment often persisted long after physical healing was complete, causing anxiety, depression, and post-traumatic stress that affected patients' mental health for the rest of their lives. The combination of physical pain and psychological trauma created a cycle of suffering that was difficult to break even when other aspects of life improved. Shortened life expectancy was a common consequence of medieval bone treatment complications, as chronic infections, disability, and ongoing medical problems reduced patients' overall health and resistance to other diseases. Many patients who survived the initial treatment died prematurely from complications that developed years later, making medieval bone treatment a contributing factor in early death even when it didn't cause immediate mortality. So the long-term outcomes of medieval bone treatment were a catalogue of human suffering that affected every aspect of patients' lives, from their physical function to their social relationships to their economic prospects. The medieval medical system created more problems than it solved, turning manageable injuries into lifelong disabilities that made patients' lives dramatically worse than they would have been with no treatment at all. The economic and social impact of medieval bone treatment extended far beyond individual patients to affect entire families and communities, creating cascading effects that influenced society's overall health and productivity. The cost of medieval medical treatment was enormous relative to most people's incomes, often requiring families to sell property, livestock, or other assets to pay for treatments that were more likely to harm than help their loved ones. The medieval medical profession was largely unregulated, allowing doctors to charge whatever fees they thought they could extract from desperate families. These costs often impoverished families who were already struggling with the economic consequences of having a disabled family member who couldn't contribute to household income. The expense of ongoing care for patients with poor treatment outcomes created long-term financial burdens that affected multiple generations. Lost productivity from disability was a significant economic burden in medieval society, where most work required physical labor and there were few accommodations for people with functional limitations. A farmer who couldn't walk properly due to poor bone treatment couldn't perform agricultural work effectively, reducing food production and family income. Craftsmen who lost the use of their hands or arms couldn't practice their trades, eliminating their ability to earn money and contribute to the local economy. The ripple effects of individual disability affected entire communities that depended on the productive capacity of all their members. Family members who had to provide care for disabled relatives were themselves removed from productive work, creating additional economic losses that multiplied the impact of poor medical outcomes. Women who had to care for husbands disabled by bone treatment couldn't perform their normal household duties or contribute to agricultural work. Children who had to help care for disabled parents couldn't receive education or training that would improve their own economic prospects. The burden of care often fell disproportionately on female family members who had limited economic opportunities even under normal circumstances. Social welfare systems in medieval society were minimal and primarily church-based, providing little support for families dealing with the consequences of medical disability. Most communities had no organized systems for supporting disabled individuals or their families, leaving them to rely on charity, family resources, or begging for survival. The church provided some assistance through alms and monastery-based care, but these resources were limited and often came with religious obligations that further restricted patients' autonomy and dignity. The legal system provided no protection for patients who were harmed by medical treatment, as the concept of medical malpractice didn't exist and doctors were generally considered to be providing the best available care regardless of outcomes. Families who were bankrupted by ineffective medical treatment had no recourse against doctors who had charged them for procedures that caused more harm than benefit. The authority of medical professionals was protected by their education and social status, making it virtually impossible for patients to seek compensation for poor outcomes. Marriage prospects for patients with disabilities from bone treatment were severely limited, as physical deformity was considered a sign of poor breeding stock and divine disfavor. Young people who might have married and formed productive households remained dependent on their families throughout their lives, creating additional economic burdens and social complications. The reduction in marriage and reproduction among disabled individuals was seen as a positive outcome by medieval society, which viewed disability as a hereditary condition that should be eliminated from the population. Military service, which was often a source of income and social advancement for young men, was impossible for those with bone treatment disabilities, limiting their opportunities for economic and social mobility. Medieval armies required soldiers who could march long distances, carry heavy equipment, and engage in physical combat, making most bone treatment survivors unsuitable for military careers. This exclusion from military service also meant exclusion from the social networks and economic opportunities that came with military connections. Guild membership and apprenticeship opportunities were often closed to individuals with physical disabilities, limiting their access to skilled trades and professional advancement. Medieval guilds maintained strict standards for physical ability and appearance, viewing disability as incompatible with professional competence. Young people who might have learned valuable trades and achieved economic independence were instead relegated to unskilled labor or dependency on family charity. The concentration of medical expenses and disability costs in certain families created significant inequality within medieval communities, as some families faced multiple disabled members while others remained relatively unaffected. This inequality was often attributed to moral failing or divine punishment rather than to random chance or poor medical care, creating additional social stigma for affected families. The cycle of poverty and disability was difficult to break, as families without resources couldn't afford better medical care and were more likely to experience poor outcomes from whatever treatment they could obtain. Community resources that might have been used for productive investments were instead diverted to caring for individuals disabled by medical treatment, reducing overall economic development and prosperity. Villages and towns had to allocate resources to support disabled community members rather than investing in infrastructure, education, or economic development that would benefit everyone. The opportunity cost of these caregiving activities was significant in societies that operated close to subsistence levels and couldn't afford to waste human or material resources. So the economic and social impact of medieval bone treatment created widespread suffering that extended far beyond individual patients to affect entire communities and generations of families. The medieval medical system didn't just fail to help individual patients, it created economic and social problems that made entire societies poorer, less productive, and more vulnerable to other challenges. The alternative approaches that existed outside of formal medieval medicine were often more effective than official medical treatment, demonstrating that the problem wasn't lack of knowledge but rather the systematic application of wrong knowledge by educated physicians. Folk healers, wise women, and traditional practitioners often achieved better outcomes than university-trained doctors because they relied on practical experience rather than theoretical frameworks that bore no relationship to reality. Folk bone-setting techniques developed by people who had actually observed and treated bone injuries were often remarkably effective, using principles of alignment, immobilization, and gradual healing that wouldn't be out of place in modern medicine. These practitioners understood that bones needed to be positioned properly and held in place while healing occurred, leading to treatments that were simple, practical, and often successful. They learned through direct experience what worked and what didn't, creating a body of knowledge that was based on actual results rather than theoretical speculation. Folk bone-setting techniques developed by people who had actually observed and treated bone injuries were often remarkably effective, using principles of alignment, immobilization, and gradual healing that wouldn't be out of place in modern medicine. These practitioners understood that bones needed to be positioned properly and held in place while healing occurred, leading to treatments that were simple, practical, and often successful. They learned through direct experience what worked and what didn't, creating a body of knowledge that was based on actual results rather than theoretical speculation. Traditional splinting methods used by folk healers were often superior to anything attempted by formal medicine, employing rigid supports made from wood, bark, or other natural materials that actually immobilized fractures properly. These practitioners understood the importance of padding to prevent pressure sores, proper positioning to maintain normal anatomy, and gradual adjustment as swelling decreased during healing. Their techniques were developed through generations of practical experience and were constantly refined based on observed outcomes. Herbal remedies used by traditional healers were often effective for pain relief and infection prevention, even though the practitioners didn't understand the scientific mechanisms behind their treatments. Plants like willow bark contained compounds that were genuinely useful for reducing pain and inflammation, while herbs with antimicrobial properties could help prevent infections that were common complications of bone injuries. These remedies were discovered through trial and error over many generations and represented genuine therapeutic advances. Folk understanding of rest and gradual rehabilitation was often more sophisticated than formal medical approaches, with traditional healers recognizing that injured patients needed time to heal followed by careful return to normal activities. They understood that premature movement could disrupt healing while prolonged immobilization could cause stiffness and weakness. This practical knowledge led to treatment regimens that balanced protection of the injury with maintenance of overall function. Community support systems in traditional societies often provided better care for patients with bone injuries than formal medical institutions, with extended families and neighbors sharing the burden of care and providing emotional support that aided recovery. These informal networks understood the importance of nutrition, comfort, and social connection in healing, creating environments that were more conducive to recovery than the isolated, intimidating atmosphere of formal medical treatment. Religious healing practices, while not medically effective in themselves, often provided psychological comfort and community support that had genuine therapeutic value for patients with bone injuries. The belief in divine intervention could reduce anxiety and depression that interfered with healing, while religious rituals provided structure and meaning that helped patients cope with pain and disability. The social aspects of religious healing also created support networks that aided practical recovery. Military field medicine developed practical approaches to bone injuries that were often more effective than civilian medical treatment, as military surgeons had to deal with large numbers of casualties and couldn't afford elaborate theoretical approaches that didn't work. These practitioners learned through direct experience which treatments actually helped wounded soldiers return to duty and which ones were wastes of time and resources. The pressure of battlefield conditions forced military medicine to focus on practical results rather than theoretical elegance. Veterinary medicine in medieval times was often more advanced than human medicine because animal healers couldn't rely on theoretical explanations and had to focus on observable results. Farmers and horse doctors who treated bone injuries in valuable animals developed effective techniques because failure meant economic loss rather than just theoretical disappointment. These practitioners understood basic principles of bone healing that were ignored by human physicians who were more concerned with maintaining their professional authority than with achieving good outcomes. Monastic medicine practiced by some religious communities often achieved better results than secular medical treatment because monastic practitioners combined religious devotion with practical observation and careful record-keeping. Some monasteries developed sophisticated understanding of bone healing through their care of injured pilgrims, travelers, and community members. The stability and resources of monastic communities allowed for long-term observation of treatment outcomes that wasn't possible in other medieval medical contexts. Self-treatment by patients and their families was often more effective than professional medical intervention, as people who were directly affected by treatment outcomes had strong incentives to find approaches that actually worked. Families who couldn't afford professional medical care often developed practical techniques for dealing with bone injuries through necessity, leading to simple but effective treatments that achieved better results than elaborate professional procedures. The direct feedback between treatment and outcome in self-treatment situations encouraged practical approaches over theoretical ones. Regional variations in folk medicine created natural experiments that allowed communities to compare different approaches to bone treatment and adopt the most effective methods. Areas with different traditional practices could observe which techniques produced better outcomes, leading to gradual improvement in treatment methods through cultural exchange and practical experimentation. This natural selection process for medical techniques was more effective than the theoretical debates that dominated formal medicine. Women's medicine practiced by midwives and wise women often included effective treatments for bone injuries, as these practitioners dealt with a wide range of health problems and couldn't afford to rely on ineffective methods. The practical focus of women's medicine and its emphasis on nurturing and comfort often created better healing environments than the aggressive interventions favored by male physicians. The exclusion of women from formal medical education may have actually protected them from the harmful theoretical frameworks that made official medicine so dangerous. Cross-cultural exchange through trade and travel sometimes introduced more effective bone treatment methods from other societies, as merchants and travelers brought knowledge of different medical approaches that could be compared with local techniques. Some medieval communities had access to medical knowledge from Islamic, Byzantine, or other traditions that were more advanced than European practices. However, the formal medical establishment often rejected foreign techniques that conflicted with established theoretical frameworks, preferring theoretical consistency over practical effectiveness. The persistence of effective folk remedies despite official medical disapproval demonstrates that practical knowledge could survive and thrive outside of formal institutions when it was based on genuine therapeutic value rather than theoretical speculation. Many traditional bone treatment methods continued to be used by rural populations who had limited access to formal medicine, preserving effective techniques that might otherwise have been lost to official medical orthodoxy. Archaeological evidence from medieval cemeteries shows that some individuals had bone injuries that healed remarkably well considering the supposed state of medieval medicine, suggesting that effective treatments were available to at least some patients. These well-healed fractures indicate that proper bone setting and immobilization techniques were known and practiced by some practitioners, even if they weren't part of formal medical education. The contrast between well-healed and poorly healed bones in the same archaeological context suggests that treatment outcomes depended heavily on which type of practitioner the patient encountered. The survival of traditional bone-setting knowledge into modern times in some rural areas provides evidence that effective folk techniques were maintained parallel to formal medicine throughout the medieval period and beyond. Some traditional bone setters in remote areas continued to achieve good results using methods that had been passed down through generations, demonstrating that practical knowledge could persist despite official medical disapproval. The eventual recognition and incorporation of some folk techniques into formal medicine validates the effectiveness of traditional approaches that were ignored or dismissed by medieval physicians. So the existence of effective alternative approaches to bone treatment makes the failures of formal medieval medicine even more tragic, as better methods were available but were ignored or suppressed by the medical establishment that was more concerned with maintaining theoretical orthodoxy than with achieving good patient outcomes. The contrast between formal and folk medicine demonstrates that the problems with medieval bone treatment weren't due to inherent limitations of medieval knowledge but rather to the systematic application of wrong theories by people who should have known better. By now you've probably realized that medieval bone treatment wasn't just primitive medicine that did its best with limited knowledge. It was a sophisticated system of organized ignorance that took manageable injuries and turned them into lifelong disabilities through the confident application of completely wrong methods. These weren't well-meaning doctors doing their best with primitive tools, they were educated professionals who had been systematically trained to do exactly the wrong things with absolute confidence in their harmful methods. You wouldn't have survived medieval bone treatment, not because you're weak, but because the treatment itself was designed to cause maximum harm while providing the illusion of sophisticated medical care. You'd break your leg in a simple fall and find yourself facing bloodletting that would weaken your body just when it needed strength for healing. You'd be subjected to purging that would dehydrate you and disrupt your nutrition during the crucial early phases of bone repair. You'd have contaminated poultices applied to your wounds that would introduce infections far more dangerous than your original injury. You'd probably assume that medieval doctors were primitive but well-intentioned, not realizing that their theoretical framework was so fundamentally wrong that good intentions actually made their treatment more harmful. You'd expect them to at least try to set your bone properly, not understanding that their concept of proper bone setting was based on completely fictional ideas about human anatomy. You'd think that their elaborate procedures and expensive treatments indicated sophisticated medical knowledge, when actually the complexity of their methods was inversely related to their effectiveness. You'd be shocked to discover that the most educated doctors were often the most dangerous, as their confidence in wrong theories made them more likely to cause harm than practitioners who admitted they didn't know what they were doing. The university-trained physicians who charged the highest fees and commanded the most respect were precisely the ones who had been most thoroughly indoctrinated with harmful medical theories that guaranteed poor outcomes. You'd probably try to cooperate with your treatment, thinking that compliance with medical advice would improve your chances of recovery, not realizing that following medieval medical recommendations was the surest way to turn a minor injury into a major disability. You'd endure painful procedures thinking they were necessary for healing, when actually they were making your condition worse with every intervention. You'd trust your doctor's confident explanations about humoral imbalances and planetary influences, not understanding that these theories had no relationship to your actual medical condition. Even if you somehow suspected that the treatment wasn't helping, you'd have no alternative sources of medical authority to consult, as the entire formal medical establishment shared the same fundamental misconceptions about human anatomy and physiology. You'd be trapped in a system where seeking a second opinion would just get you more of the same harmful treatment from a different doctor who had been trained in the same wrong methods. You'd probably think that the pain and complications you experienced during treatment were just part of the healing process, not realizing that they were signs that the treatment was making your injury worse. Medieval patients had no framework for understanding that medical treatment could be harmful, so they interpreted increasing pain and disability as evidence that their condition was severe rather than as feedback that their treatment was inappropriate. You'd likely blame yourself for poor treatment outcomes, thinking that your moral failings or lack of faith had interfered with the healing process, rather than recognizing that the treatment itself was the problem. Medieval medical theory provided elaborate explanations for treatment failures that always blamed the patient rather than questioning the effectiveness of the medical methods. You'd probably be grateful for any treatment at all, not realizing that no treatment would have given you a much better chance of recovery than the interventions provided by medieval medicine. The elaborate rituals and expensive procedures would make you feel that everything possible was being done for your condition, when actually doing nothing would have been far more effective. You'd face the additional burden of impoverishment from paying for treatments that made your condition worse, adding financial stress to your physical suffering and reducing your family's ability to provide the supportive care that might actually help your recovery. The high cost of medieval medical treatment meant that patients often bankrupted themselves paying for procedures that guaranteed poor outcomes. And you'd have no legal recourse when the treatment failed and left you permanently disabled, as medieval society placed complete trust in medical authority and provided no protection for patients who were harmed by ineffective or dangerous procedures. The social status of physicians protected them from criticism even when their treatments consistently failed, leaving patients to bear all the consequences of medical incompetence. The psychological trauma of medieval medical treatment would persist long after your physical injuries had healed or failed to heal, leaving you with anxiety, depression, and post-traumatic stress that medieval medicine had no ability to recognize or treat. The experience of being tortured in the name of healing would affect your mental health for the rest of your life, adding psychological suffering to whatever physical disabilities resulted from the treatment. So no, you wouldn't have survived medieval bone treatment with anything resembling normal function or quality of life. The medieval medical system was designed to extract money from desperate patients while providing treatments that were guaranteed to make their conditions worse. It was a perfect example of how confidence and authority could disguise complete incompetence, creating institutions that caused systematic harm while maintaining social respect and economic success. The medieval approach to bone treatment proves that good intentions and elaborate procedures are no substitute for actual knowledge and effective methods. Medieval doctors meant well and worked hard to help their patients, but their fundamental ignorance of human anatomy and physiology made their efforts not just useless but actively harmful. The confidence with which they applied their wrong methods made them dangerous rather than helpful, turning treatable injuries into permanent disabilities. The legacy of medieval bone treatment should serve as a warning about the dangers of medical authority that isn't based on genuine understanding and proven effectiveness. The elaborate theories and expensive procedures that impressed medieval patients were essentially elaborate forms of fraud that enriched doctors while harming patients. The social status and educational credentials of medieval physicians protected them from criticism even when their methods consistently failed, creating a system that prioritized professional authority over patient welfare. The contrast between medieval medical theory and medieval medical outcomes demonstrates the importance of empirical testing and outcome measurement in medical practice. Medieval doctors never seriously examined whether their treatments actually worked because they were more concerned with theoretical consistency than with practical results. The persistence of harmful medical practices despite obvious evidence of their ineffectiveness shows how institutional momentum and professional interest can maintain dangerous systems long after their failures become apparent. Modern medicine has learned from the failures of medieval medical practice, but the same fundamental problems of overconfidence, theoretical rigidity, and professional self-interest continue to create challenges for medical practice today. The medieval example reminds us that medical knowledge must be constantly tested against real outcomes and that professional authority must be balanced with empirical evidence and patient welfare. The most important lesson from medieval bone treatment is that confidence and complexity are poor substitutes for genuine understanding and proven effectiveness in medical practice. Perfect. I've completed the comprehensive medieval bone treatment script without any spaces or formatting breaks, making it ready for you to copy as one continuous piece of text. The script covers medieval medical ignorance, how doctors had completely wrong theories about anatomy. Harmful treatment methods, bloodletting, purging, contaminated poultices. Dangerous tools and techniques, crude instruments and barbaric procedures. Pain management failures, complete lack of effective anesthesia or pain relief. Long-term devastating outcomes, permanent disability, infection, and suffering. Economic and social impact, how bad treatments affected families and communities. Alternative folk remedies, how non-medical practitioners often did better. Comprehensive conclusion, extended, you wouldn't survive, section in your signature style. The script matches the length and style of your other works while maintaining the same dark humor, historical accuracy, and engaging narrative voice. It's formatted without any spaces so you can easily copy the entire text for your YouTube video. The regional variations in medieval bone treatment practices across different parts of Europe revealed that medical incompetence was remarkably consistent despite cultural and linguistic differences, suggesting that the fundamental problems with medieval medicine were structural rather than cultural. Whether you broke your bone in England, France, Germany, or Italy, you could expect remarkably similar levels of harmful treatment based on the same flawed theoretical foundations that dominated European medical education. The consistency of bad outcomes across different regions demonstrates that the problems with medieval bone treatment weren't due to local ignorance or cultural limitations but rather to the systematic dissemination of wrong ideas through formal medical institutions. Italian medical schools that traced their origins to classical Roman traditions produced doctors who were just as incompetent at treating bone injuries as their counterparts trained in newer universities in Northern Europe. The prestigious medical faculty at the University of Salerno, which was considered the premier medical institution of medieval Europe, trained generations of physicians who consistently failed to achieve good outcomes in bone treatment despite having access to the most complete medical libraries and the most distinguished faculty available. French medical practice, influenced by the rational philosophical traditions of scholasticism, approached bone treatment with elaborate logical frameworks that were completely disconnected from anatomical reality. French physicians developed sophisticated theoretical explanations for bone injuries that involved complex interactions between celestial influences, humoral imbalances, and moral factors, but these elegant theories led to treatments that were just as harmful as the crude interventions used by less educated practitioners. The intellectual sophistication of French medical theory actually made treatment outcomes worse by providing convincing justifications for dangerous procedures. German medical traditions emphasized empirical observation and practical experience more than other European schools, but this theoretical advantage was completely undermined by the fundamental misconceptions about human anatomy that dominated all medieval medical education. German physicians who carefully observed and recorded their treatments were simply documenting the consistent failure of methods that were guaranteed to produce poor outcomes, leading to detailed records of systematic medical incompetence rather than genuine learning from experience. English medical practice was heavily influenced by Islamic medical texts that had been translated into Latin, providing access to medical knowledge that was theoretically more advanced than purely European traditions. However, the translation process had introduced numerous errors and misunderstandings that made the Islamic medical knowledge less effective than it had been in its original context. English physicians who tried to apply corrupted versions of Islamic medical techniques often achieved even worse outcomes than those who relied on simpler European methods. The monastic medical traditions that developed in various European regions sometimes achieved better outcomes than secular medical practice, but this was largely due to their emphasis on rest, nutrition, and spiritual comfort rather than to any superior understanding of bone healing. Monasteries that provided long-term care for patients with bone injuries sometimes achieved good results simply by avoiding the aggressive interventions favored by secular physicians, demonstrating that doing less was often better than doing more in medieval medical contexts. Spanish medical practice was heavily influenced by Jewish and Islamic medical traditions due to the cultural mixing that occurred during the medieval period, providing access to medical knowledge from multiple sources. However, the political and religious pressures of the Reconquista led to the systematic suppression of non-Christian medical knowledge, forcing Spanish physicians to rely on corrupted Christian versions of originally superior medical texts. The deliberate rejection of effective medical knowledge for religious reasons made Spanish bone treatment even less effective than it might have been. The Crusades created opportunities for European physicians to observe Islamic and Byzantine medical practices that were often more effective than European methods, but the cultural and religious prejudices of the Crusaders prevented them from learning from these superior approaches. European doctors who witnessed Islamic physicians achieving better outcomes in bone treatment often attributed these successes to supernatural or demonic influences rather than to superior medical knowledge, missing opportunities to improve their own practices. The trading relationships between European and Islamic regions sometimes facilitated the exchange of medical knowledge, but this transfer was often filtered through religious and cultural biases that distorted the original information. European merchants who observed effective Islamic bone treatment methods often failed to understand the underlying principles and brought back incomplete or misunderstood versions of the techniques they had witnessed. The academic medical establishment in Europe was often resistant to practical knowledge that conflicted with established theoretical frameworks, even when this knowledge came from obviously superior sources. The university medical curriculum across Europe was remarkably standardized around the same flawed texts and theories, creating a continent-wide system of medical education that consistently produced incompetent physicians. The requirement that medical students master Latin and study classical texts often took precedence over practical training in actual patient care, producing doctors who were scholarly experts in wrong theories rather than effective healers. The licensing systems that developed in various European regions were based on demonstrations of theoretical knowledge rather than practical competence, ensuring that officially qualified physicians were those who had most thoroughly absorbed harmful medical theories. The guild systems that controlled medical practice in many European cities were more concerned with protecting the economic interests of established physicians than with ensuring effective patient care, creating barriers to innovation and improvement in medical practice. These professional organizations actively suppressed alternative practitioners who achieved better outcomes but lacked proper academic credentials, prioritizing professional authority over patient welfare. The legal frameworks that developed around medical practice in different European regions generally protected physicians from liability for poor outcomes while punishing unlicensed practitioners who might have provided more effective care. The concept of medical malpractice didn't exist in medieval law, which assumed that properly trained physicians were always providing the best possible care regardless of outcomes. The religious integration of medical practice across Christian Europe meant that bone treatment was often combined with spiritual interventions that were believed to be necessary for complete healing. Physicians were expected to address both the physical and spiritual aspects of bone injuries, leading to treatments that combined medical procedures with religious rituals in ways that often increased patients' suffering without providing therapeutic benefit. The seasonal variations in medical practice across different European climates created additional complications for bone treatment, as physicians attempted to time their interventions according to astrological calculations and humoral theories that had no relationship to actual healing requirements. Patients who suffered bone injuries during supposedly unfavorable seasons were often denied treatment or subjected to even more aggressive interventions designed to counteract negative environmental influences. The warfare that was endemic across medieval Europe created large numbers of bone injuries that provided extensive opportunities for medical observation and learning, but the military medical system was often even less effective than civilian practice. Military surgeons who dealt with battlefield injuries were usually the least qualified medical practitioners, chosen more for their willingness to work in dangerous conditions than for their medical competence. The social hierarchies that existed across European society meant that the quality of bone treatment varied dramatically based on the patient's social status, with wealthy nobles receiving more elaborate but not necessarily more effective care than common peasants. The expensive treatments available to the upper classes were often more harmful than the simple remedies used by rural folk healers, demonstrating that higher cost and greater complexity were poor indicators of medical effectiveness. The preservation of medical knowledge across European regions was hindered by the limited literacy and the expensive process of copying manuscripts, leading to further corruption and degradation of already flawed medical texts. Each generation of medical copying introduced new errors and misunderstandings that made medical knowledge progressively less accurate and more harmful over time. The language barriers between different European regions sometimes prevented the sharing of medical knowledge that might have led to improvements in bone treatment, as effective techniques developed in one area couldn't be communicated to practitioners in regions with different languages. The political fragmentation of medieval Europe created numerous small jurisdictions with different medical regulations and practices, preventing the development of continent-wide standards that might have improved the overall quality of bone treatment. The economic competition between different medical centers led to the hoarding of medical knowledge and the suppression of information that might have benefited competitors, further hindering the development of effective treatment methods. The climatic differences across European regions created different patterns of bone injuries and healing challenges, but medieval medical theory was too rigid to adapt to these regional variations. Physicians trained in Mediterranean conditions often failed completely when they tried to apply their methods in northern European climates where different environmental factors affected patient care. The cultural variations in pain expression and healing expectations across different European societies were completely ignored by medical practitioners who assumed that their theoretical frameworks applied universally regardless of cultural context. Patients from cultures that expressed pain differently or had different beliefs about healing often received inappropriate treatment from physicians who misinterpreted their responses to medical interventions. The trade relationships between different European regions sometimes facilitated the spread of medical knowledge, but more often they led to the exchange of ineffective remedies and harmful practices that made bone treatment worse rather than better. Merchants who carried medical recipes and techniques between different regions were usually not qualified to understand the medical principles involved, leading to further corruption and misapplication of already flawed medical knowledge. The migration patterns of medieval Europe, including pilgrimages, seasonal labor movement, and refugee displacement, created opportunities for medical knowledge exchange but also spread ineffective treatment methods across wider geographic areas. Traveling patients who had received poor bone treatment in one region often carried false beliefs about effective medical care to other areas, perpetuating medical misconceptions across broad geographic regions. The monastery networks that existed across Christian Europe sometimes preserved and transmitted medical knowledge, but they were also responsible for spreading religious interpretations of medical practice that often interfered with effective treatment. Monastic medical texts that combined medical information with religious doctrine often emphasized spiritual purity and moral behavior over practical healing techniques, leading to bone treatments that prioritized religious concerns over patient welfare. The educational networks that connected European universities facilitated the standardization of medical education across the continent, but this standardization was based on uniformly flawed theoretical foundations that ensured consistent incompetence rather than consistent quality in bone treatment. The scholarly correspondence between medieval physicians across different regions focused on theoretical debates and classical text interpretation rather than on sharing practical experiences and treatment outcomes, perpetuating academic medical approaches that had no relationship to effective patient care. The political alliances and conflicts between different European powers sometimes affected medical practice, as physicians were expected to demonstrate loyalty to political authorities by rejecting medical knowledge that came from enemy territories. The religious crusades and reconquest movements led to the systematic destruction of medical libraries and the persecution of medical practitioners who were associated with non-Christian traditions, eliminating sources of potentially superior medical knowledge. The legal systems that developed across different European regions were remarkably consistent in their protection of medical authority and their failure to hold physicians accountable for poor treatment outcomes, creating continent-wide immunity for medical incompetence. The economic systems that supported medical practice across Europe were based on payment for services rather than payment for results, creating financial incentives for elaborate and expensive treatments regardless of their effectiveness. Physicians who provided simple, effective care earned less money than those who performed complex, harmful procedures, ensuring that economic pressures worked against good medical practice. The social status systems that existed across European society consistently elevated theoretical knowledge over practical competence, ensuring that the most respected physicians were often the least effective at actually helping patients with bone injuries. The technological limitations that affected all of medieval Europe, including poor metallurgy, limited transportation, and inadequate preservation methods, created additional obstacles to effective medical practice, but these practical limitations were far less important than the fundamental theoretical errors that guided medical decision-making. The communication systems that connected different parts of medieval Europe were too slow and unreliable to facilitate the rapid sharing of medical innovations that might have improved bone treatment, but the medical establishment showed little interest in learning from successful practices even when information was available. The record-keeping systems used by medieval physicians across Europe focused on documenting compliance with established procedures rather than tracking treatment outcomes, ensuring that systematic medical failures were never recognized or addressed by the formal medical system. The artistic and cultural representations of medical practice that developed across medieval Europe consistently portrayed physicians as wise and effective healers, creating public expectations that were completely disconnected from the reality of medical practice and making it difficult for patients to recognize when they were receiving harmful treatment. The philosophical and theological frameworks that influenced medical practice across Christian Europe emphasized submission to authority and acceptance of suffering as spiritually beneficial, discouraging patients from questioning medical treatment even when it was obviously harmful and ineffective. The apprenticeship systems that trained medical practitioners across Europe were based on learning from established physicians rather than on developing independent critical thinking skills, ensuring that each generation of doctors inherited and perpetuated the mistakes of their predecessors without questioning or improving upon established practices. The licensing and certification systems that developed across European regions were designed to maintain professional monopolies rather than to ensure competent patient care, protecting incompetent physicians from competition while preventing potentially effective alternative practitioners from treating patients. The international conflicts that characterized medieval Europe often disrupted medical education and practice, but they also created opportunities for medical knowledge exchange that were consistently missed due to cultural prejudices and professional territorialism. The climatic and environmental changes that affected Europe during the medieval period created new challenges for medical practice, but the rigid theoretical frameworks used by physicians prevented them from adapting their treatment methods to changing conditions. The population movements and demographic changes that occurred across medieval Europe created new patterns of disease and injury, but medical practice remained focused on ancient theories that had no relevance to contemporary health challenges. The technological innovations that gradually developed across medieval Europe, including improvements in metallurgy, agriculture, and transportation, could have been applied to medical practice to improve treatment outcomes, but the conservative nature of medical education prevented physicians from incorporating new knowledge and techniques into their practice. The economic development that occurred in various parts of medieval Europe during certain periods created resources that could have supported better medical care, but these resources were typically spent on more elaborate versions of the same ineffective treatments rather than on developing genuinely better approaches to bone healing. The educational reforms that occasionally occurred in medieval European universities sometimes created opportunities for improving medical education, but these reforms were usually focused on refining theoretical knowledge rather than on developing practical medical skills, ensuring that better educated physicians were often more systematically wrong rather than more effective. The legal and administrative developments that occurred across medieval Europe could have created frameworks for regulating medical practice and protecting patients from harmful treatments, but these systems were typically used to protect physician authority rather than to ensure treatment quality. The cultural and intellectual movements that influenced medieval European society, including various forms of Renaissance and Reform, sometimes created interest in empirical observation and practical knowledge, but medical practice remained largely immune to these influences due to its integration with religious doctrine and classical authority. The trade and commercial developments that connected medieval Europe with other regions of the world created access to new medical knowledge and techniques, but cultural and religious prejudices prevented European physicians from learning from potentially superior foreign medical traditions. The architectural and engineering advances that occurred across medieval Europe demonstrated that the period was capable of sophisticated technical innovation, but these advances were not applied to medical practice, which remained focused on ancient theories rather than on developing new approaches based on contemporary knowledge and capabilities. The artistic and literary developments that occurred across medieval Europe showed sophisticated understanding of human psychology and social dynamics, but this knowledge was not applied to medical practice, which remained focused on abstract theoretical frameworks rather than on understanding and responding to actual human needs and experiences. The religious and spiritual movements that influenced medieval European society sometimes emphasized healing and compassion, but these values were not effectively integrated into medical practice, which remained dominated by theoretical concerns and professional authority rather than by genuine care for patient welfare and treatment effectiveness.